Welcome to this month's online session discussing the impact of CRM on survival and recurrence after incomplete TME for rectal cancer. Today's presenter and co-author is Dr. Ali Alipouriani, and our guest moderator is Dr. Guilherme Pagin São Julião.
Hi, good evening, everybody. Welcome to this Technique in Coloproctology virtual meeting. It's a pleasure to have you all here. My name is Guilherme Pagin São Julião. I am one of the associate editors from the journal, and I'll be moderating this session tonight. Tonight we have here Dr. Ali Alipouriani, who will be presenting his manuscript that has just been published in the journal. Dr. Alipouriani is a research fellow at the Cleveland Clinic, just graduated from medical school, and will be here tonight as our colorectal surgeon. It's your word. Welcome. Thank you very much for accepting our invitation. Take your time, present everything about your manuscript, and after that, we're gonna open for questions from everybody who is connected, and we're gonna make a great discussion tonight.
Thank you. Thank you for this opportunity, and thank you, the journal, for making this opportunity for us to discuss a little bit more about our paper. So I've prepared some slides that I'll share. Can you please confirm that you can see my screen?
Yeah, we can see.
Thank you so much. So hi everyone, and thank you for being here today. So today I'll be presenting our recently published paper in Techniques in Coloproctology. The title is Margin Matters, Impact of Circumferential Margin Involvement on Survival and Recurrence After Incomplete Total Mesorectal Excision for Rectal Cancer. So as I was introduced before, I'm Ali Alipouriani. I'm a research fellow in colorectal surgery department of Cleveland Clinic, and Cleveland, Ohio. So before diving into the details of our study, I would like to take a moment and acknowledge and thank all co-authors for their contribution to this study. So with that, let's get started by discussing some background on total mesorectal excision, or TME, and the role of margin status in rectal cancer surgery. So I have no conflict of interest to disclose for the study. And so rectal cancer accounts for a large proportion of colorectal malignancies, with approximately 45,000 new cases annually in the United States. The total mesorectal excision, or TME, is the gold standard surgical technique for rectal cancer. It involves sharp dissection along the embryologic mesorectal plane, carefully removing the rectum and mesorectal fat as an intact unit. These techniques ensure preservation of the mesorectal fascia, reducing tumor spread, and improving oncological control. The TME was pioneered by Holt in 1982, replacing the traditional blunt dissection methods, which had high recurrence rate of up to 30%. But with TME, local recurrence dropped below 10%, and overall survival improved significantly. However, TME can be incomplete in about 5 to 30% of cases because of various large series and meta-analysis. Incomplete TME often arises from difficult tumor anatomy, bulky disease, or inadequate dissection, which can leave behind mesorectal tissue and raise the risk of a positive circumferential resection margin, or CRM. The circumferential resection margin, or CRM, is one of the most clinical prognostic factor in rectal cancer surgery. A positive CRM, commonly defined as a tumor extension within 1 to 2 millimeter of radial margin, and has been repeatedly shown to increase local recurrence rate and reduce survival. Rickles in 2015 and Leonard in 2016 found that patients with positive CRM have nearly double the local recurrence risk and significantly shorter disease-free survival compared to those with negative margin. This concept was first introduced by Quirk in 1986, who demonstrate the CRM involvement leads to a high rate of pelvic recurrence. Later studies confirm that CRM less than 1 millimeter is an independent predictor of poor prognosis, even after controlling for tumor stages and lymph node involvement. So what does that mean in real-world clinical practice? If a patient has a positive CRM, it significantly alters treatment decisions. This patient often require intensified adjuvant therapy, even if they have already received neoadjuvant chemoradiation. Additional post-operative therapy is frequently recommended also. The local recurrence rate exceeded 30% in CRM positive patients compared to less than 10% in those with negative margins. Overall survival and also is significantly worse when CRM is involved. So let's look at the real world case example. Imagine a 65 years old male undergoing a low anterior resection for rectal cancer, and the final pathology revealed a CRM of 1 millimeter. In this scenario, even though the surgery technically achieved an R1 resection, the positive CRM placed the patient at the high risk of recurrence. The oncologist would likely recommend adjuvant chemoradiotherapy despite the patient having undergone neoadjuvant therapy before. Close MRI surveillance and CA level monitoring would be necessary for early detection of recurrence also. From the surgeon's perspective, how we can prevent positive CRM. Preoperative MRI assessment is crucial to estimate CRM risk before surgery, and total neoadjuvant therapy, or TNT, is increasingly used to shrink the tumor and improve margin clearance. Sharp dissection along the mesorectal plane is essential to achieve the complete TME, reducing the risk of positive margins. As mentioned earlier, because the margin clearance is so critical, neoadjuvant approaches such as standard chemoradiation or TNT are increasingly used to downsize the tumor preoperatively, thereby improving the likelihood of negative CRM. Even so, incomplete TME can still jeopardize margin status, and actually this is what led us to investigate whether negative margin can mitigate the typically poor prognosis seen in incomplete TME. Given the known challenges in incomplete TME, our study aimed to investigate how circumferential margin status, specifically positive versus negative margin, affect local and systemic recurrence, disease-free survival, and overall survival. We also explored how neoadjuvant treatments approaches modified this outcome. We conducted retrospective analysis of patients who underwent proctectomy for rectal adenocarcinoma at our institution between 2010 and 2022, focusing on those with incomplete TME on final pathology. After identifying this patient, we categorized patients into 3 groups. The first group was involved CRM, or positive margin, where the tumor extended to the ink margin. This group revealed to have an associate with the worst oncological outcome, including higher recurrence and poorer survival. And the second group was uninvolved CRM, equal or less than 2 millimeter, where the tumor is close to the margin but doesn't reach it. And the last group was uninvolved CRM that greater than 2 millimeter, where the tumor is well away from the margin, which is considered the safest margin distance. So the important question here is why we use 2 millimeter as our cutoff instead of the more commonly used 1 millimeter. And the reason was, first, we in our data set include very few patients with margin equal or less than 1 millimeter. And I think it was around 5 patients, which made a statistical analysis challenging. The second reason was we tested both 1 millimeter and 2 millimeter cutoffs, that the results were similar. But the 2 millimeter threshold allowed for better statistical power. So we extract demographic variables, preoperative details, neoadjuvant therapy usage, and pathological outcomes such as margin distance and tumor grade. The primary endpoint were local recurrence and overall survival, and the secondary endpoint included systemic recurrence, disease-free survival, and time to detection of local or systemic recurrence. Out of 7,941 proctectomies performed between 2010 and 2022, 236, that was around 3%, met our criteria for incomplete TME. The median age was 64 with a slight male predominance at 62%. The staging spanned from stage 1 to 4, with the largest proportion being stage 3, that was 46.5%. Before surgery, 60% of patients underwent standard neoadjuvant chemoradiation, whereas about 14 received total neoadjuvant therapy or TNT. Abdominal perineal resection or APR was the most frequent procedure performed in about 54% of cases, which may reflect advanced or distal disease. Approximately 62% of surgeries were minimally invasive, and the median operative time was under 5 hours, and post-operative complications include a 14% readmission rate and a 7.5% reoperation rate. Notably, 23% of the patients had positive margin upon final pathological review. One of our key findings was local recurrence. That was 20.4% in patients with positive margin versus 9.4% in those with negative margin. That the p-value showed a significant difference between these two groups. And the Kaplan-Meier analysis indicate a significantly shorter interval to local recurrence among patients with involved margins, underscoring the adverse impact of even focal margin involvement. Systemic recurrence was 22.2% in patients with positive margin versus 20.4% in those with negative margin. And disease-free survival was 45.2 months in patients with positive margin versus 58.9 months in those with negative margins. The median overall survival was significantly reduced for patients with positive margin. That was 60.5 months compared to 87.3 months for those with negative margins. When we subdivided the uninvolved margin into less or equal than 2 millimeter and greater than 2 millimeter, actually we didn't find any major difference in survival between these two groups. However, margin involvement itself remaining a strong independent predictor of mortality, showing about a 3.4-fold higher risk compared to those with uninvolved margin in multivariate models. This suggests that the study achieving a negative margin is a critical factor with a negative margin. The exact distance, less or equal than 2 millimeter versus greater than 2 millimeter, did not significantly alter survival. So we also examine how margin status and recurrence vary by neoadjuvant approaches. Among our cohort, the margin positivity rate was significantly lower, was 8% in patients who received total neoadjuvant therapy compared to 30% with standard chemoradiation. Interestingly, local recurrence appeared lower with TNT, 4%, than standard chemoradiation that was 15.6%. This suggests TNT may enhance tumor shrinkage and facilitate clearer margins. Our data reinforce that a positive surgical margin is a key prognostic factor in incomplete TME cases, roughly doubling local recurrence and reducing both disease-free and overall survival, and this aligned with the prior literature reporting worse outcome for R1 resection margins. And the total neoadjuvant therapy was associated with less margin involvement, suggesting improved downstaging and ultimately achieving negative margin even under incomplete TME circumstances can have a critical impact on long-term survival. So we acknowledge limitation, including the single institution nature of our data set, And it's a retrospective design which can introduce selection bias toward more advanced or anatomically challenging cases that got referred to this institution. Although our study highlights the impact of CRM and the benefits of TNT, there are still major unanswered questions. One of the most important research area is how to further optimize TNT. We need trials actually investigating whether timing and sequencing of neoadjuvant therapy can improve margin clearance. And additionally, MRI-based prediction models could help personalize TNT based on the tumor characteristic. Uh, in summary, our study highlights the critical impact of circumferential margin status on oncological outcome in rectal cancer patient undergoing incomplete TME. A patient with positive margin faced double the recurrence risk and significantly worsened overall and disease-free survival, making margin status one of the most crucial prognostic factors. So with that, while negative margin help mitigate poor outcomes, they are not a substitute for complete TME. This underscored the importance of optimizing resection techniques whenever possible. Importantly, TNT significantly lowers margin positivity, suggesting its potential role in improving resectability. Moving forward, surgeons and oncologists must focus on multimodal strategies, precise surgical techniques, appropriate neoadjuvant selection, and individualized patient treatment, and to improve patient survival. Thank you so much for your time and attention.
Thank you very much, Ali. So we're gonna have some time for discussion now. If anybody wanna make some questions, you can either post it on chat or raise your hand, and we're gonna give you the word to speak it personally. Before we get to any questions from the audience, I'll start making a question for you. So I saw that you correlate your specimens with positive CRM and negative CRM. I was wondering if you consider it to look at the YPT status of these patients, because as you demonstrated, lots of TNT has less positive CRM and better outcomes. I was wondering if it is not because this patient had more pathological complete response or near complete response. Did you by any chance get this correlation with YPT status?
I would say no, but we respond to your question. We just exclude those patients with near incomplete and complete response that was reported by our pathologist, because there is obvious about complete response, but about incomplete response, there is kind of bias in pathological assessment, and it's very, very, I can say it's there's a variability in interpretation in near complete resection, and in compared with TNT, yes, I would say most of the research nowadays showed that TNT would reduce both both local recurrent and systemic recurrence. But in our data set and our paper showed that it actually proved about the local recurrence, but about systemic recurrence, it demonstrated that has a higher systemic recurrence. But I think maybe as we explained in the paper, it may be due to some factors such as variation in tumor biology or tumor resistant to chemotherapy or micrometastasis that were not fully removed. Maybe those reasons that makes we demonstrate systemic recurrence in TNT group was higher than the other one. But I acknowledge this fact. But the existing literature has shown that TNT improved local and systemic recurrence. But I think our findings suggest that need for further investigation into those factors I pointed out earlier. And yeah, I think there is a possibility to investigate further about that.
Yeah, I understand your point. In my opinion, we need to be clear that TNT will not replace a full TME, a complete TME, because one thing is giving more treatment for those patients who had poor prognosis features on the MR pre-operatively or pre-treatment, and then we can improve their outcome. But this will not replace a positive CRM. Your study clearly demonstrate that those patients who had TNT has less CRM positivity compared to
Yes.
those that did not.
Yes.
And when just to clarify for the audience, I don't know if everybody got a chance to read the manuscript. We're here looking only at those patients who had an incomplete TME, right, Ali?
Yes.
So an incomplete TME is those patients who were meant to have a complete TME, a TME, not a partial mesorectal excision, but a total mesorectal excision, and end up with a specimen that did not fulfill all the criteria for a complete TME. That means they had tears in the mesorectal reaching to the muscularis, right?
Yes, exactly.
And then my question came to the near complete response, which was not clear for me, that was excluded, but now it's clear, because we know that patients that have TNT, they have higher rates of near complete response and pathological complete response compared to those that had standard treatment, or, well, not even saying that no treatment. Before we have questions from the audience, I'm gonna make you another question, and you feel free to explain everybody if you are familiar with this situation, because it's something more related to how to care the patients in your institution, or not because you're a research fellow and you're not dealing with the patients nowadays. There is still some controversies if patients with rectal cancer that goes to neoadjuvant treatments or TNT or standard to have a reassessment magnetic resonance scan before their operation to plan for the operation. And this is quite important because the reassessment scans will guide the surgeon to know if he can cut through a plane or not. You clearly demonstrate that the majority of your patients underwent an abdominal perineal excision, which means the intersphincteric plane was probably compromised. And then there is always this controversy if we should believe on the baseline staging or in the reassessment staging. And this was not discussed in the manuscript. So I wonder if you can clarify for us if usually these patients have the reassessment scans, and if the decision on the operation is based on the baseline scans or on the reassessment scans.
Actually, I'm not quite familiar to what is happening before the surgery and how the surgeon and the team is decided for the surgery. But I know before the surgery, for most challenging cases, at least I would say, we had a tumor board that's a multidisciplinary tumor board that they go through the patient details and kind of discuss about everything about that patient individually. I would say yes, and they have a oncology surgeon, they have a colorectal surgeon, and pathologists and radiologists as well go through the patient condition and tumor characteristic, and both together decide to what they exactly should do for this individual patient. And but the answer for your question, I think yes, they kind of reassess the patient based on the MRI after that, and then based on that they decide if this patient is the time for surgery or not, or maybe they can, I don't know, delay the surgery for further chemoradiation, or maybe extend the period or not.
Okay. But not a commentary, more than a question. So you demonstrated that those patients who had a positive CRM had a recurrence rate of 20%, 22%, if I'm not wrong. Is that it?
Yes.
I found this quite surprising, quite good, in fact, because usually patients with positive CRM have nearly 50% local recurrence rate. Do you have any commentary on this? Or
Not as actually specifically about that, but this is what we found really interesting in our cohort, that the patient who had a positive margin that was around 54 patient had around 22% recurrence, that make it significant in compare with the other groups.
okay. Well, Dina, you want to say something?
Oh, there's a comment in the chat section.
I
from the
cannot see here. If you can read for us, because for me it's not
Sure.
presented.
It says, not clear the concept. Does TNT have less possibility in getting an intact total mesorectal excision? And could you rephrase? Ali?
I was reading the question.
Oh,
Yes,
okay.
in our study, yes, it completely showed that the patient who had actually showed that the patient who had a TNT had a less positive margins that in compare with total no in compare with neoadjuvant chemoradiation, and we, as we explained in paper, that maybe is because of the shrinkage of the tumor, and the actually make it easier to resect the whole mesorectum. And I think that, yeah, we showed that the patient who had who got a TNT had a less positive margin involvement.
Was that clear for you, Eduardo?
He says, okay, yes.
Okay. Perfect. So, Ali, do you have any final considerations, the message you want to give people regarding incomplete TMEs?
Well, actually, I I can say the one of the most important things for anything that related for this to this paper is uh, when we have incomplete mesorectal excision. So what is happening next? And we showed that maybe negative margin involvement can kind of compensate incomplete mesorectal excision. And it's very important, sometimes due to some anatomy differences, or high BMI, or other demographic related to the patient characteristic, we couldn't reach the incomplete mesorectal, and we are gonna end up with incomplete. But we should notice that if we in those patients who had incomplete, it's very important that in patient who had a positive margin has a very different outcome than those who had a negative margin in incomplete mesorectal excision. And any different kind of treatment like a TNT or neoadjuvant therapy can help us to reach the better outcome, to have incomplete to have a complete mesorectal excision. And I think that's a key point of our study that all of us should have in mind when we end up with incomplete mesorectal excision.
I need to say something.
Sure.
I don't fully agree with this conclusion for your manuscript from one point, and I'll tell you why. I don't think your data can say that a negative margin after an incomplete TME can compensate the incomplete TME. Because to say that, you would need to compare to complete TME, and you did not.
No, maybe I said wrong. I was actually I was saying in those who had incomplete, because all the patient in our paper is about incomplete mesorectal
Absolutely,
excision.
yeah.
And in those patients, I would say in patient who had a positive margin versus negative margin. I didn't say that in patient. I'm not comparing incomplete versus complete. I would say maybe negative margin in incomplete mesorectal excision can compensate the outcome of positive margin, not not complete mesorectal excision. I'm comparing the positive margin versus negative margin.
Yeah. We have another question from Dr. Cedric.
Oh, you can see them now. Okay, I'll let you take over.
Okay, thank you, Gina. I'll read it for you, Ali. So he's asking, how accurate is pathology reporting on CRM? The distance between a tumor cell on hematoxylin and eosin to the mesorectal fascia seems detectable. Is there anything known on this?
I don't want to say something that I'm not sure about. Actually, it's kind of related to pathology, but I can say in the pathology report we kind of completely obvious part about the mesorectal excision, that is it incomplete, near complete, or incomplete, and so most of the time one pathologist looking at the mesorectum, the specimen, and decide is this specimen is complete or incomplete. But for most challenging cases or specimen, they're gonna be two pathologists, and they both have decided to actually make a comment on that. But I'm not quite sure about this. If they how they I don't know how they reporting and based on what, or hematoxylin and eosin on the mesorectal fascia. I'm not quite sure about that.
Yeah, so just complementing what you just said, I think they're quite accurate in reporting CRM.
Yes.
Because usually they use inks all around the mesorectal, and then when they look on H&E, they can see the color, the ink color, and if the tumor is in touch with the color they just put around the mesorectal, they can see there is a positive margin because the tumor is reaching there. Otherwise, it is involved by mesorectal tissue.
Yes.
So we have some more questions. Yes,
Yeah,
go ahead.
Sorry. We explained that in paper that the positive margin is when the margin involved when the pathologists actually see the involved ink margin, and they explain it as write as a positive or involved margin. Otherwise, it's gonna be negative.
Yes, absolutely. This is quite useful tool that pathologists use to report the positive CRM. So Dr. Kuma is asking, did the patient who had CRM positive went to have adjuvant chemo?
Yeah, that's a great question, but actually in our study we didn't look at that in post-operative patient who had a positive. So but I know maybe around 50% based off the tumor characteristic and the pathological report after the surgery. I can say some of the patient had received the adjuvant therapy after the surgery as well. Yes.
Okay.
And,
Yes.
Yeah.
Go ahead.
Yes.
So Dr. Salgado is asking, in case that the surgeon noticed an incomplete TME, do you recommend, or do you know if in your institution they recommend intraoperative radiotherapy?
For this patient that we look at as an incomplete incomplete mesorectal excision, I would say maybe very few patients got an intraoperative radiotherapy or IORT. But no, I would say no. During for most of the patients, didn't receive intraoperative radiotherapy.
Okay. I have one further question for you, Ali. I don't know if you
Sure.
you can answer for me. So again, coming back to the abdominal perineal excision, we know that abdominal perineal excision is a quite difficult operation, more difficult than standard total mesorectal excision. And I'm telling this because there is data showing that the rate of positive CRM after abdominal perineal excision is higher than after intersphincteric dissection or low anterior resection. My question is, one of the tools we've been using to reduce the rates of positive CRM after abdominal perineal excision is performing extra levator abdominal perineal excision. Do you know if this has been implemented in your institution, if there are patients operating having the extra elevator abdominal perineal excision, or they're still having the standard operation?
Honestly, no, I'm not actually really have any idea about the answer. Maybe that's a really great idea. I think for future studies, I think that's very interesting to see if comparing those procedures together and see what is happening, what's the outcome after that. But for now, no, I really I can't answer that because we haven't looked at that. I'm not quite familiar with that.
That's okay. Dina, do we have any further questions?
No, not at the moment.
Okay. Well, so I think we're getting to the end. I want to thank Dr. Alipouriani for your great discussion and your thoughts about this interesting and sometimes neglected subject, because usually people just discuss about the complete mesorectal excision and not the incomplete, because they're very rare. As you demonstrated, 3% only of the proctectomies had incomplete mesorectal excision, so it's quite difficult to get these large numbers and to bring some data about it. So thank you very much. This was really, really interesting. I hope everybody has enjoyed, and thank you.
Thank you so much
Yes,
for the
thank you
opportunity.
very
Thank you
much.
so much.
So thank you everybody for being here, and we'll let you know for the next sessions that will come up the following months. And
Also,
yes,
the video of this presentation will be on our YouTube channel soon. And make sure to subscribe to the YouTube channel. And we're also on LinkedIn and X.
perfect.
Yes.
Thank you
Thank
so
you very
much.
much. Bye,
Thank
everybody.
you.
Thank you.
Bye-bye.
Bye.
See you next time.
Thank you for watching. The published article discussed in this virtual session can be found on your screen. For more TCOL content, visit link.springer.com/journal/10151. Be sure to subscribe to our YouTube channel to be notified of our next virtual session. You can find us at youtube.com @Coloproctology.